thank you everybody for this opportunity. Thank you, Anthony, for the invitation, and thank you also to Claire for your ongoing friendship and collaboration in this space. So I've got a big disclosure to make before I start. I've never treated an eye tumour, and so why am I standing in front of experts and consumers talking about eye cancer? Well, it's because something really exciting is happening in Adelaide over the next couple of years, which I think is important for this group to know about, because there may be some momentum to use protons in this country in the treatment of ocular cancer. But I'm a radiation oncologist. I normally treat head and neck cancer and brain tumours and prostate cancers, but I'm also a qualified GP, and I currently work at the Royal Adelaide Hospital. So this is the building in the centre there that will be built in the next 2 to 3 years. It is a 14-storey facility, which is the final jigsaw piece in this so-called biomedical precinct. It comprises of the new $2.3 billion, believe that or not, Royal Adelaide Hospital, SAMRI 1, which is a research facility, the University of Adelaide and the University of South Australian Health Precincts. And so it is this massive total $3.6 billion facility that has been has come out of the ground over the past 7-8 years. And so the so-called SAMRI 2 building will house the Australian Bragg Centre for Proton Therapy and Research. And so this is how it's going to look. We've secured Commonwealth funding to the tune of $68 million, with some money also from the South Australian state government, and building works are about to start hopefully in 2019. It's a very complex build. Building a particle therapy service is completely different than laying concrete to build standard linear accelerator facilities. The complexity is 10 times fold. And this is another render from the North Terrace aspect of Adelaide. This is a floor map of the centre. This is 3 stories below ground. The reason for that is because the so-called gantries in those 2 big rooms are literally 2.5 to 3 stories high, and they're essentially steel structures that house tons and tons of superconducting magnets, which actually bend the beam, which I'll tell you about in a second. But down the bottom, there's an empty room, and that's where our fixed beam line is going to be housed. And this is why I'm here to talk to this community about the possibilities in that space. And so this is a typical modern treatment room for a proton therapy facility. Patients sit on a robotic arm, and there's various image guidance technologies that are employed. What's interesting about this photo, of course, is that the treatment beam comes from the left there, but that whole thing is on a rotating gantry, which I've just described, which is 3.5 stories. So the patient doesn't see that, but outside of that room, it's quite fascinating. The technology, as Claire alluded to, for proton therapy is not new. This is technology that has actually been in existence for over 70 years. I've circled when the cyclotron was invented. That actually predated the development of modern linear accelerators that form the part of the linear accelerators that give standard radiotherapy. But a lot of these facilities were actually physics research facilities studying fundamental laws of physics and particles. And it was only until 1990 that the first clinical proton therapy service opened in Southern California. And so why are we using particles over photons? Well, it's because of this so-called Bragg peak. In the bottom right part of the slide, you'll see a red line, and that describes the percent depth dose curve of a proton. And what's relevant here, if I can use this marker, is at the entry dose. So the dose that the body receives at entry is very much lower compared to the X-rays denoted in green. And then as the proton slows in tissue, it then rapidly deposits energy in a very finite region in the so-called Bragg peak, beyond which there's 0 dose. And you can use other ions apart from hydrogen, which is a proton to do this, including carbon ion, amongst many others. This phenomenon was actually discovered in Adelaide, and this man and his brother went on to win the Nobel Prize in Physics for that discovery. And so why are protons of interest to radiation oncologists around the world and here in Australia? It's because there is an elimination of unnecessary radiation dose with proton therapy. And so there's 3 panels there. In the middle is best practice modern photon or X-ray based therapy. And then on the left is proton therapy. So these are dose washers or heat maps, if you will, describing various levels of dose, with red, being the high dose, and then out to blue, which is low dose. And you can see on the far right the actual subtraction of the protons from the photons. And this is the unnecessary radiation dose that's delivered, unfortunately, with even best practice photons. And it's particularly relevant in patients like children who need radiotherapy as part of their treatment package, including patients that need something called cranial spinal irradiation. And you can see in this photo that on the right, with X-rays, there is a lot of unnecessary low and intermediate dose, unnecessarily going into abdominal and thoracic organs, which can cause late effects, and you compare that to protons on the left. And so that's very important for the young child and young adult, because their organs are still developing, and we know that radiotherapy has many associated late effects, which are progressive and often permanent and take many years to manifest. And so this is a comparative plan that we do at the Royal Adelaide Hospital as part of the MTOP process to select or inform applications to seek Australian federal funding for treatment with proton therapy overseas prior to our unit opening in Adelaide. And so you can see on the left the plan that we generated. This is not for ocular melanoma, I should note. This is for a recurrent orbital rhabdomyosarcoma in a young person. And you can see protons on the left and photons on the right. And so the blue is unnecessarily, or the blue dose wash is unnecessarily going through the contralateral eye and a lot of the developing brain, including the hearing apparatus inferiorly, the pituitary glands, some of the important deep neural brain structures like the hippocampus, which are associated with long-term neurocognitive sequelae from radiotherapy. And so this is a rapidly expanding movement, I should say, around the world. This is the world with all the current treating proton facilities denoted in red, and then the far fewer carbon ion facilities or other ion particle accelerators, mainly in Japan and Europe. But you can see there's 80 already in operation, 66 in various phases of planning or construction, and there's many big multi-institutional, multinational trials consortia that are studying this, including ours here in Australia, the Tasman Radiation Oncology Group, which is our lead clinical trials group for radiation oncology in Australia. And so we're modelling this, and this work has been done for several years to justify the money that's required to build a facility like this. And so there's a big evidence base for very few malignancies that clearly are best treated with protons due to that unnecessary dose that you avoid delivering with the use of this technology over standard photons. But that list does continue to grow, and there's a growing body of evidence that's coming year on year that suggests that, in many patients with with malignancies that don't usually fit on that initial indication list may actually derive a benefit for a variety of reasons. So we've got national guidelines which are on the web. Ocular melanoma, I think, is the fourth malignancy on that table. And so that formed part of the business case to government to get a proton facility up and running. And this is currently under review by the federal government to give the Australian people an item number to access proton therapy here as part of the MSAC process. Until then, patients, like I've said, can access proton or even other particle therapy overseas with the aid of the MTOP application. And as part of that, we do dosimetric comparative plans at the Royal Adelaide Hospital to inform that decision. And so this is an example of a 3-year-old with a condition called craniopharyngioma, who had a comparative plan at our unit, and you can see clearly the advantages of intensity modulated proton therapy with something called pencil beam scanning. That's just one of 2 techniques to deliver proton therapy compared to best practice VMAT photon radiotherapy. So currently there's only, to my knowledge, about 12, maybe 13, I know the South Korean unit just started treating eyes the late last year with a synchrotron-based solution. But there are very few centres, despite 80 in operation, only about a dozen or so treat eyes with a dedicated eye line. And the reason is there are other established radiotherapeutic modalities available to patients in countries that don't have proton facilities. And we've talked about stereotactic-based treatments already. And the reason for the paucity of dedicated eye lines is that they are actually expensive. These are additional capital costs over and above the actual cost of the machinery that are required to bring it alive. And so that's going to require grants and philanthropic donations potentially. And I make the point that, it is really important to hear the consumer perspective on this going forward, because I think that's a very powerful thing, certainly in the particle therapy community here in Australia, which is a growing collaborative, just like this group, we're very... we dedicate whole sessions to consumer sessions at each symposia that we've held. And as we talked about yesterday, the importance of national ocular melanoma guidelines are going to help. That will evolve over the next 12 to 18 months, I hope. Will essentially decide as a community here with consumer input, do we actually need a dedicated eye line in this country for this condition? And so there are a few lessons, I think, to learn from the other places around the world that are delivering proton therapy for ocular melanoma. The UK is just about to, it's just opened the first national NHS proton facility at the Christie in Manchester, and the UCLH hospital in central London is going to come online in about 3 years. That's a far more complex build because they've got massive infrastructure around it to build around. And so they've very arduously just spent the best part of a decade coming up with the platform to collect vast amounts of data to basically help inform policy going forward in light of the relative paucity of both acute and long-term effects of proton therapy for many of these malignancies. And so I think there's lots of lessons for this Australian community here. And we've talked about some of this stuff over the past day or two. And I would also, just in my last couple of minutes, just to bring your attention to a variety of different approaches that are currently being tested around the world, including model-based approaches out of Holland in particular. So their patients go through this model-based approach which essentially helps clinicians, informs clinicians and patients who are likely going to derive the most benefit, the most bang for their buck, having protons over photons. Make no mistake here, modern radiotherapy is remarkable, it's magical, it's amazing what we can do to sculpt dose around very unusually shaped structures anywhere in the body. And so these novel approaches, I think, are going to help tease out the nuances between protons and photons going forward. And so here is what the Dutch do. So they use something called a normal tissue complication probability as a predictive biomarker. So essentially what they're doing is they're doing a plan using photons, and then they're comparing it to a plan using protons, and then looking at something called a dose volume histogram, essentially a chart on the bottom right. What's the difference in dose to, let's say, a parotid gland for a patient with oropharyngeal cancer? We know parotid glands, when they're unnecessarily irradiated to a dose beyond which the gland can take, you're left with lifelong xerostomia or dry mouth, which is a debilitating quality of life issue for patients. And so this is what they generate, and then they had these arbitrary thresholds, which if you meet as a patient, well then you go down the proton pathway. Otherwise, if you're under the tolerance using best practice modern photon radiotherapy, you have photons, and you're going to get a good job. We know because we've prospectively looked at that. And this is going to be all incorporated in prospective national databases and registries, and all of it's going to feed into each other. And then the machine learning and artificial intelligence algorithms are then going to have vast amounts of data over the next couple of decades to sift through. I'll skip this slide. So thank you. Again, thanks for the invitation, and I welcome any questions. Thanks.